I'm Dean Newlund, and welcome to the Business of Intuition, where I coach, facilitate, train, and speak on the hard science and meaningful experience of intuitive leadership in business, so you can make better decisions, forge real connections, and creatively solve problems to amplify your impact and simplify your life. Welcome to the Business of Intuition. Our quality of life is intrinsically linked to the quality of our health. Leading a company, building a team, or enhancing your personal brand becomes extremely challenging when you're unwell or injured. Injuries and illnesses are obstacles that hinder leadership, team development, and culture building. Who wants to run a meeting when you're feeling sick? This interview targets both care providers and patients who are seeking the highest quality of health. A major complaint among care providers is a lack of autonomy. And according to my guest, large healthcare systems inadvertently cause burnout, whereas smaller independent practices create much less burnout. Our medical education system, tax structure, and insurance practices encourage the expansion of large healthcare systems. However, my guest wants care providers to know that there are alternative options. Patients, on the other hand, seek, of course, personal relationships with their primary doctors and care providers. They want ease of access, and of course, they want insurance coverage that pays for their medical bills. Small, independent practices offer an attractive alternative for certain levels of care, and rural communities particularly benefit from smaller providers. My guest, Dr. Marcelo Hochman, is a well-known speaker and double board-certified facial, plastic, and reconstructive surgeon on a mission to build better medicine for patients and doctors, not just better business. Recognized by CNN, Wall Street Journal, and USA Today, Dr. Hochman led the national charge on providing PPE for medical staff during COVID and is the president of Indedocs, an organization founded to help provide more options for patients and doctors and disrupt the controlling and limiting healthcare bureaucracy. Dr. Marcelo Hochman on the Business of Intuition. So, Dr. Hochman, it is really a unique opportunity to talk to you because we get a lot of people on the show over the last 4 years who talk about a lot of different things relative to culture and leadership and coaching and so forth. I think you are my first person showing up to this podcast in medical scrubs. So it's, and I know you're a physician and have been for years, and you have some very passionate ideas that I don't think most people quite understand. That, you know, as I told you, that we've got a lot of work that we've been doing over the years in healthcare. And, you know, the things you hear are that we're moving more towards a system enterprise-wide model, that the small, you know, independent general practice physician is the thing of our childhood. You know, we're not going to see that. You know, we're going to have to go to these large hospital systems or outpatient systems to be able to get care. You told me something that I didn't know, that doesn't necessarily have to be, that's a misnomer, that's a misunderstanding. Tell us why it's important that, one, from a patient perspective and also a physician perspective, why we should continue to support the independent healthcare provider.
So, you know, from the physician point of view, if you look at, you know, a lot of the data and the stories, and, you know, a big topic is burnout.
Yes.
Right. I mean, so burnout is in the lay press, it's in the medical journals. And it's interesting to me that if you look at the causes of burnout that are listed, the single most important one is a lack of autonomy. The physicians finding that they are not in control, or they don't have a say in what they're doing. You know, they're employed, therefore the agenda is of the employer. And even though they practice medicine, they have to practice medicine within certain parameters. And they have to do it a certain way. You know, they have to see patients X number of minutes, and they have to have, you know, all this chart work that needs to be done. I mean, it goes on and on and on. But it's interesting when I look at the burnout and listen to the burnout talks and all that, I think I don't experience any of that.
Hmm.
That doesn't mean that every day, every part of my day is wonderful, and but I am in control of every single part of my practice. I'm not saying it's easy. I'm not saying it's all fun, and it's not that, I mean, obviously, it's and it's not for everybody, but I am convinced that the whole burnout topic for most people would be resolved by just having control over their practice. So I talk to residents and medical students, and when I talk to them about sort of what they might be doing in the future, I tell them, the most important thing is to create the environment that you want to practice in.
Mm-hmm.
And everything else really follows from that. So to me, the one of the issues that we see with healthcare systems, getting bigger, and we can talk about all that kind of stuff, but the effect on the doctor is that the doctor has become sort of at the bottom of a very tall list of employees. And if you look at the number of doctors employed and, it stays about the same, the number of physicians, but the administrative layers above them gets bigger and bigger and bigger. And my individual needs as a physician may be number 1, 2, and 3, but when I rank them within a system, I mean, they may not even be in the top 100, So
Right.
again, all of a sudden I have no say, so.
Right.
So
And
anyways.
I totally understand. And I've seen some of that data as well. So I'm with you 100%. And I'm not a physician. As we know, when we talked earlier, we do a lot of work with physicians, and burnout is one of those things that keeps coming up over and over again. I think I heard, I don't know whether this is accurate, but during COVID, we lost something like 500,000 nurses across all healthcare systems due to burnout and the onslaught that was coming up with COVID. So, and I'm hearing over and over again, more about this than I do, that we need more care providers as the aging population increases. We need to find a way to attract these people into a very, very important part of our overall determinants of health, which is, in this case, healthcare, notwithstanding economic and social and all the other stuff. So if I'm a physician, let's just go down that road for a second, and then want to get to the other side of the equation with respect to the patient. If I'm a physician, I don't know whether anybody wakes up as a physician and goes, after a few years, I want to be a part of a large healthcare system, unless they grew up through that system. Like, you're Mayo medical student, you become a resident, then they hire you on. That's all you've ever known, right? You've never been on your own. But those who've been on their own, the reason that I thought that they would want to be absorbed into a larger healthcare system is because the headache of running a business on top of the care and the art of being a physician is just too much, or maybe the financial concerns, or the fact that it's hard to get good people to be coordinators or what have you. So I want to be able to do my art, my job, my passion without all the headache of running a business. And therefore, yes, maybe I have to sell my practice, but at least I've got security. How do you answer that?
Right. So you mentioned two things which I think are key. One is, one of the problems in medical education now is there's very little exposure at the medical student, resident, or fellow level to private practice.
Interesting.
So those medical students, exactly like you said, they are growing up in system medicine. All their mentors have been employed and only know system medicine. So there are very few specialties that have built into their programs interaction with exposure to private practice, right? So as a pediatrician, you may come out of residency never having talked to somebody who's in private practice. And so you assume that the only thing that there is to do is to be a pediatric hospitalist or something. And I'm just making that up as a specialty. But so that's one key thing, is that we are not exposing the young generations to independent practice. So that's one of the things which is a problem. And I think where academic medicine is failing the profession and the public. Number two, what you mentioned about physicians saying, I just want to practice medicine, therefore employment is the answer. That ends up to be really not the case, right? Because the employment the security was what you mentioned, which I think is what drives most people, the financial uncertainty of how to do it, right? And then the burden, regulatory burdens and all the things, EMRs and all these kind of things are very expensive and all
medical
that.
insurance.
However, there's alternatives to that. I mean, you can have a pediatric subscription-based practice. I have one here in Charleston. Don't take insurance. It's all cash, very reasonable fees. You have access to your physician, right? So there are ways in every single specialty. There may be a couple like lab-related things that may be a little bit more difficult. But so if you want to play the third-party payment game, there are a lot of boxes that need to be checked literally to be able to do that, right? There's EMR. And so it could be very burdensome. It doesn't mean it's impossible, but that is where people then say, well, I'd rather have a paycheck and not deal with. But it turns out that by not dealing with it, you end up feeling very frustrated, because all of a sudden you're being told you have to see 25 patients and you can only spend so many time, so it's a double-edged sword. And I'm not saying that private practice is for everybody or that employment is for nobody. I mean, there's
that's
plenty
great
of opportunity on both sides, right?
And we got to obviously take care of and look at the quality of life for the physician, the care provider. That's important, obviously, because if they're not doing well, they're probably not going to be providing the right kind of level of quality care. It's if you got a sick doctor, how do you provide wellness to a patient?
And the thing is, it's frustrating me to hear because what you're saying is what you hear, right?
Yeah, I'm here to get reaction from you. Yeah,
no, exactly. Yeah. In the old days, and I'm getting to the point where I'm looking back on the older days, but my mentors, you would hear about doctors burning out at the end of their careers because they had been taking care of patients all their life.
Yeah.
They had missed family events. They had missed this. They were always on call. They were available, but they loved what they did.
Yes.
They got tired at the end of it, but they had extremely fulfilling careers. And they would look back and say, this was amazing, right? Now you're talking about burnout in medical school.
I know. Isn't that amazing? They haven't even gotten into an OR yet.
Or done much of anything other than you're studying hard. But to me, that is a symptom of the problem within the system. And what are the systems telling physicians to do? Be more resilient, take classes, do pottery, whatever, spend more time, in the gym or whatever. To me, it just seems this very unreal way of practicing medicine. I mean, most doctors want to take care of patients, right? They don't need a break from taking care of patients. They ended up needing a break from the system or the environment that they're working in. And that is a very different issue. So anyway, from the physician point of view, I think that we need to, one, educate those in training and expose them to private practice and what that means, right? And how to do it and what are the opportunities. And again, the security of a paycheck isn't always worth, what you get for that,
Is, according to the research that you've been able to get a hold of in your own experience, burnout higher in a system, less for the independent provider? Or are
absolutely.
They the same? You're saying, so basically it sounds like what you're saying is that the systems help encourage the burnout that physicians and care providers rail against later.
Absolutely.
That's a pretty strong line in the sand. I mean, I love it. I mean, it's very, very clear. So then if it is about being able to encourage people to really continue staying in an independent practice, obviously, like you said, there's a variety of different challenges that affords itself, and it's not for everybody, right? Being an entrepreneur is not everyone's cup of tea. But to your point, you do have autonomy where others do not. What sort of other kinds of recommendations might you have for people maybe considering going into the care provider industry or those who are already in? How do we migrate more towards a system that encourages the independent?
So I think we're at a point, and again, when you look at the data that show that now more than 50% of physicians are employed, that seems to be the story, right? The demise of private practice. The way I see it is that there's still 40 to 50% of physicians who are independent and are doing fine, and we just need to grow that number back up. Okay, so yes, the trend clearly was, in the old days, everybody was independent. I mean, that's how medicine started.
Right.
And then eventually, the employment model for a variety of different things, first physician-owned groups are still a great model. At least they're physicians who own the practice. And then it's gone more and more towards, doctors practicing in environments in which they don't have ownership.
Yes.
And that's a problem. But the flip side to that is there's still a big group. I mean, we're not down to like 90-10. I mean, we're just, 40-60, so I mean, we're just on the other side of 50-50. So to me, the opportunity is huge because of some of the things that have happened, for example, in our state, where we repealed the certificate of need. That's one big door that opens.
Explain that to our listeners. What is the certificate of need?
So the certificate of need was a federal program that was started in the 70s. The goal was to control costs, avoid duplication of services, increase access, increase quality. There were 5 things that the federal government said. We will help control the market by putting in the requirement that in order to open up a certain facility or provide a certain service or spend X amount of money improving certain things, you have to get a certificate of need. You have to prove that there's a need. A few years later, the federal government said, this isn't working, literally. I mean, none of the 5 things were happening. But by then, the states had already enacted their own certificate of need laws. So what does that mean? Is that in order for you to build an MRI center or an imaging center, you had to get a certificate of need. You had to apply for a hall pass from the state to open up your business. In South Carolina, in addition to that burden, was that those who already had a certificate of need, i.e., the hospitals, could contest your application and they would block it, basically. So over time, what that did is just consolidated. It reduced the number of facilities and the number of services available, which guess does what? Increases prices, right? I mean, it's just a supply and demand thing.
Right.
So for decades, that's what was happening. And it's like McDonald's being able to tell Burger King that they can't open across the street,
Got it.
They actually do that on purpose because it's good for everybody's business and for the public, right?
Right.
But the hospitals would block the opening up of any surgery center or anything like that to drive business into the hospital. So now your MRI costs $3,000, whereas in an independent imaging center would have been $300, right?
Understood. Okay.
So we, 6 years ago, when I was president of the Charleston County Medical Society, embarked on eliminating the certificate of need in South Carolina. And 6 years later, as of today, the certificate of need has been repealed in a year and a half, including for hospitals. So if you want to build a hospital and you can meet the licensing requirements, or you have the money to do it, in a year and a half, you can build a hospital. Today, you can open up a birthing center, a drug rehab center, an imaging center. I mean, so the door opened for 20-something things that were being restricted by the certificate of need because people didn't have the money to contest it. And the hospitals would spend a decade, literally, fighting each other to open up a hospital, spent millions of dollars. At the end of the day, they all built whatever they wanted. But in the meantime, that community didn't have a hospital.
Right.
So
And that's across the board. That every state has that.
yes, so the certificate of need
Yeah.
was in all the states. However, there are states that repealed them earlier. There's some that have modified them. South Carolina this past year it was almost a complete repeal. I mean, it was a big deal. It is a big deal. So that is a door that opened in our state for now for a physician to be able to open up a kidney stone center or a birthing center. I mean, you could do whatever you want at this point, right?
Mm.
The second thing that's happening now nationally, which I'm sure you've heard about in the last few days, is the Federal Trade Commission has passed a rule banning non-compete clauses.
Correct.
It turns out that when I was president of Charleston County Medical Society, the second thing that we wanted to do was to ban non-compete clauses as a condition of employment for physicians in South Carolina. And that's what we're working on now.
Got it.
So if a doctor can practice wherever he or she wants to, i.e. no non-competes, and can provide whatever service he or she wants to, i.e. no CON, which is done, that opens the door for a lot of possibilities,
So you've sort of talked about the physician side. Let's talk about the patient side. Let's talk about why would they want to work with or go find a independent doctor versus a system. So let me lead into this for a second. I just saw some interesting data recently that said patients, according to this one study, want quality. They want credible doctors. But when they make a decision, the first thing they look at is it covered by my insurance, number one? And number two, how close is it to get there? Access. So under that sort of backdrop, what's the benefit for the patient to want to take the extra time to seek out an independent physician or care provider versus the big hospital system that is probably popped up all over the place?
Right. So that is the reality of where we are today, but that's part of what we're wanting to change. And again,
Understood.
in our state, those two things that I mentioned are going to lead in that direction. From a patient's point of view, the insurance thing is a reality, which is why Indedocs is working on this network of independent practices. And if you're in a practice that wants to participate in third-party payment options, then great. There are, in Indedocs, in our organization, there are practices that are solely dependent on third-party payments, right? Only insurance.
Mm-hmm.
Others that are only cash, and others that are hybrid. My practice, for example, is a mix of both. I see patients who have insurance, who don't have insurance, who have insurance, who don't want to use their insurance because it's too expensive, and I do a lot of pro bono care. So I can do whatever I want as an independent physician. You walk into my office, regardless of your financial condition, I can take care of you, right? I have control over that. As a patient, quality, of course, is you want to go to see a good doctor and you want to get good care. No question about that. As we mentioned when you and I were talking before, it is now acknowledged that outpatient service, so we're not talking about emergency and we're not talking about inpatient care stuff, but outpatient care, which is what 90% of our care is, right, is better, more quality, more efficient, more cost efficient, more cost effective when provided or done in an outpatient facility, which is independent, versus that same service provided in a hospital-owned outpatient facility. So as a patient, if you're seeing a doctor within System X, because that's what your employers and your employer benefit puts you into this insurance plan, and that insurance plan is within the system. If your doctor leaves, you just get assigned a new doctor in that system. Patients don't like that.
No.
Patients want to follow their doctor. That's why the non-compete thing is so important.
Yes.
So all things considered, you would rather, I think, and in my experience has been, the patients would rather walk in to an office where they're seen on time, where everybody knows what their issue is. If they have a complaint, they can talk to one person who will take care of it, as opposed to being, phone tree down the line to some patient representative who, you may or may not have any knowledge of this situation. And the physician whom you have a problem with probably doesn't even know it within the system, you know?
Right.
Whereas in my office, if there's a problem, I mean, I know within 5 minutes and we can take care of it within 5 minutes, you know?
Right.
So from a patient point of view, the experience, which again is a buzzword now in the whole system medicine thing, is the patient experience. If you look at what they're trying to emulate, is
Yeah.
exactly what happens in independent practices. It's pretty
Fascinating.
simple. You know, the hospitality industry has done this for years, right? No matter how big the hotel is, they make you feel like
You matter
you matter. Well, it's very easy to do
when it's
in a
smaller.
smaller unit, you know.
So you mentioned the hospitality reference, and it makes me think about sort of concierge medicine,
Mhm.
where you might pay an extra few bucks to be able to get the phone number of your doctor that you can call him or her on the weekend. Is the independent movement moving more in the direction of concierge medicine? Is that sort of their potential or one of their differentiators? Is that heightened level of experience and access that you just can't get in a large system because, again, keep pushing buttons on the phone before you finally get to a human being?
Right. So concierge, unfortunately, is I think an unfortunate term because it denotes or connotes that it's very expensive or that it's,
Right.
For the elite or somehow a little bit inaccessible to the. That's how it all started, right? I mean, but a membership or subscription model, which is really what concierge medicine is readily accessible. I mean, you don't necessarily pay exorbitant fees. I mean, there's all sorts of, but yes, that is one way that private practices can operate. I mean, that's one business model, right? But it's not the only model. I mean, you can be an independent practice that does only third-party insurance, right?
Yeah.
And you can do, like I said, a hybrid model. But our interest is to let physicians know that there are these options, and regardless of your specialty, you can do any of these, And from the patient point of view, I mean, I see this literally every day. So I have an appointment in the local medical school, so I'm an affiliate professor there, and I have residents that come through my office. I operate at the Children's Hospital. I mean, that's why I'm in Scrubs, once a week. And that's a big system, right?
Mm-hmm.
I mean, it's a big system. It's a big academic medical center, does amazing stuff, heart transplants and all that.
Mm-hmm.
But for outpatient stuff, it's a mess. I mean, patients are waiting 6 months to get an appointment, or again, it's not their doctor, or somebody else gets they're seeing a PA when they really want to see their physician, that kind of stuff. So I see both sides of this,
Yeah.
and patients prefer easy access, convenience, all those kinds of things. And there is no better model than the doctor that knows you, that, can see you, within a week, and even though even very busy practices are more accessible than giant practice, again, for outpatient things,
Are there any systems out there that are kind of a hybrid of what you're describing, where you've got outpatient that is providing that kind of access, providing that personalized service? You hear that all the time, in the marketing, literature regarding companies. It's all about personalized service, right? But there's some that are really doing it, whereby the system itself isn't getting in the way of what the ambulatory process is trying to accomplish.
Right. And then that's the problem, is that, at least in our state, the hospitals are building everywhere. I mean,
Yeah.
so, that's the big push right now, is to put facilities everywhere.
Yeah.
But guess what? Those facilities are being run by the hospitals. So they're run like a hospital. They will never be as efficient, ever be as efficient as a smaller facility. You don't have to have this big thing in order to provide a really great service. What I envision is a bunch of little things all over the state. The hospitals are building big things all over the state. Well, you open up a little thing that can compete with the big thing, And you can be phenomenally successful financially. You'll be providing an amazing service to the community, and the hospital can't compete, because they are run, that outpatient surgery center is still run like a hospital and by the hospital.
But isn't some of those ambulatory outpatient centers really seen as a benefit to a large healthcare system because it's a feeder into the hospital? It becomes a way to getting more patients in bed.
Well, and it
For the higher priced,
subsidizes
higher reimbursements and all that stuff.
right.
The cancer, the surgeries, and all that.
And I've said during testimony and at the legislature and all that, if I was a hospital administrator,
yeah,
I'd be doing the same things they're doing. They have created this thing that needs to survive. And unfortunately, that model is not very sustainable and a very efficient, high quality. And I'm not saying there's not high quality care. If I have a brain tumor, I want to be treated in a hospital, right? In a really good hospital. But if I have a broken arm, I want to be treated in an outpatient surgery center, which is going to be quicker, and anyway, so there are multiple examples. But yeah, the system gets in the way of itself because they're all volume driven, right? It's all about the market share and all that kind of stuff, which honestly, in a private practice, you don't have to worry about market share. You don't have to own the whole thing.
But you're not just talking about for-profit enterprises. You're also talking about nonprofit.
Well, so that's a whole different conversation.
That's a whole nother conversation. But
not-for-profit hospitals, that is purely an accounting, thing. Not-for-profit hospitals get far more tax benefit than the community gets in services. And that's a big topic now. Are not-for-profit hospitals should they be categorized as for-profit hospitals because they don't pay taxes.
Right.
And then they're supposed to give back to the community. So you see all these reports about how many millions of dollars they've given back. It's not, there's lots of data. There are a lot of data out there that show that the benefit to the community is outweighed on the hospital side by the tax benefits that the hospital receives.
But what are you measuring? Are you measuring what? That
like
that
charity care. Yeah. So for example, charity care is a wastebasket term that includes true pro bono care, upfront pro bono care. The hospitals also report undercompensated care as charity care. I bill you $100, you pay me $50. I just did $50 worth of charity care. That ain't charity care.
Yeah.
That's just uncompensated or undercompensated care. When I do pro bono care, you and I agree up front that I'm not going to charge you for this, right? That is true pro bono volunteer charity care. What the hospitals claim as charity care is not pro bono care. They get compensated for most everything that they do. And what they then get the tax benefit for outweighs the value to the community. I'm not saying they don't do a great job in a lot of things, but if they all paid taxes, cities would do far better than having a not-for-profit hospital in the community.
Well, we haven't talked about another character in this drama, which is the insurance company and how they set rates and the reimbursements and all of those different things that go a part of that. So in one hand, again, I'm not an expert in this, so I'm really just, I'm batting way above my abilities here. But my wondering is, okay, maybe charity care, we're not necessarily accounting for it correctly, but you're kind of robbing Peter to pay Paul to say, okay, we're not, it's not completely dollar for dollar over here, but when it comes down to it, it's overcoming some of the shortfalls that we're getting when it comes to the fact that we're not being paid dollar for dollar from our insurance company. So isn't that sort of the whole overall mix of being able to justify to be able to keep these systems going?
Yeah, it is part of the, financial machinations that happen in order to what is becoming unsustainable systems in terms of where they're getting paid from, how they're getting paid, where their money has come from. A for-profit hospital, this is a theoretical, hypothetical, but real example. Children's Hospital was built, $500 million. Okay. If a for-profit hospital had built a children's hospital, and I know this from talking to them, it would have cost $250 million. Okay. But the way that the state and the academic centers and the breaks that they get allow them to spend far more than they generate, in terms of actual income, so they're constantly fundraising and doing all sorts of things to kind of keep this thing propped up. Whereas the for-profit hospital has to be very careful. And I'm not saying it's all good on the for-profit side either, but I'm just saying my practice, I have to be very careful about whether I'm going to buy a piece of equipment or not.
Right.
I have to justify it. I have to see whether I can afford it or not. It doesn't quite work the same way on the not-for-profit side or on the academic medical center side that are being subsidized by a lot of other things that give them benefits that practices or for-profit hospitals do. But regardless, my intent is not to change the whole system. Honestly, I've said
get it. Yeah, you're not against the systems itself.
I'm not against the system. When I need my heart transplant, I want that to have available. What my whole impetus is to give doctors and physicians alternatives out of the system. Again, I am very happy owning a very small piece of the pie as a single physician, as a single practitioner, that kind of thing. I don't feel like I have to have the biggest practice in the state. The systems do. They feel like they have to be the biggest because that's what volume drives them. The insurance part is another thing that we can talk about.
Truly, I get that.
But my goal is to let doctors and patients know that there are ways to practice medicine that patients like better, are more cost efficient, are at least as good quality. Let's not say higher quality. Let's say at the very least as good quality, and that doctors can be happier in, that they're in control of and they can manage their practice. And, and that's what drives me. Charity care is the third. So there are three things that I'm interested in. Actually, you've hit on two out of three. One is the non-competes, one is the certificate of need, and charity care. So one of the things that we've done when one of our state senators, we helped draft a bill that never went anywhere federally, but it was a bill that would incentivize charity care, right? So as a physician, if I do something pro bono, that's just it. I did it pro bono and that's that. A hospital does something charitably, they get a tax benefit for that. Okay, so this bill would amend the tax code so that an individual doctor, a physician, the person giving the care, would get a tax credit for the pro bono care. And there were all sorts of requirements. You weren't going to get rich off of this. There were caps on how much, but if I did something that Medicare would have paid $100 for, then I would get $100 tax credit on my personal return, right? That relationship had to be addressed beforehand. There are all these requirements that would require me to say this is charitable care, right? It has to be, you have to be part of an organization, all this kind of stuff. It wasn't, I didn't get paid, so I want to take a tax credit for, So again, if a doctor could practice wherever he or she wanted, could provide whatever service he or she wanted, and was given an incentive to provide charity care, which every single physician I know would be happy to do. And a lot of them don't do it now because, one, if you're employed, you can't get unfunded patients into the hospital whenever you want to, right? And two, if you're in private practice, there's a limit to what you can do because you have a practice to run, right?
Yes.
But if there was an incentive for you to do that, those three things change the landscape of healthcare in our state. You can have a small, 2 OR, endoscopy suite, in a rural town, Patients don't have to travel to the urban center, and they can have their procedure done there, whether it's insurance or whether it's not or whatever. That's what I envision, is a lot of little things, a lot of little options, rather than everybody having to go to these big systems.
You bring up a great point, because they keep I couldn't help but be very city centric, where there's healthcare all over the place. Down in Phoenix, where we do a lot of our work, there's popping up healthcare centers all over. And but when you get out of the rural area, where do you go? Do you have to drive 5-6 hours in to get, a nosebleed taken care of? What are you going to do?
Right.
To your point's really well taken, especially when it comes to those smaller independent care providers that.
And South Carolina is a very rural state.
Yeah.
There are 3 big cities, maybe 4 big cosmopolitan centers, and a lot of rural space in between,
Right. And again, what I'm sort of hearing you say, going back to the patient side, is there's a certain kind of bond and a relationship that one has with a care provider, that if we can stick with that person, non-competes aside, and that's no longer around, and I can follow my doc, we can have the long-term relationship with them. My wife is now trying to get some work done, and lo and behold, her care provider has retired. Now she's got to start all over again with somebody else. The whole process of being able to get medical records shared is now really difficult. And it's just it's a pain in the butt, just to try to navigate all this within a system. So your point's really well taken. So Dr. Hochman, how can people learn more about you? If you're a care provider and you've got some great questions that have been generated based on this conversation, or you want to know more about what your organization's doing, how do they connect with you? And also, maybe as a patient, do you have any resources that you might be able to provide people who think, all I can do is always go to the big hospital system? I didn't know that there was an option.
Sure.
Could you provide us maybe some final thoughts on resources?
Sure. So as far as physician resources, that's what in our state, Indedocs, or INDEDOCS, Independent Doctors of South Carolina.com. And I'm sure you'll have the URL available, and through LinkedIn and all that kind of stuff. As far as patients are concerned, or even, physicians also, you're welcome to share my email address. It goes directly to me, and I'm happy to, I have a very niche practices. I have one practice that is children with vascular anomalies. It's a very niche practice. I see more of those kids than anybody else in the state, and I see them from all over the country and internationally. So I'm very used to patients emailing me and asking me, and I'd be more than happy to address. We've had physicians from other states ask us, how do we start an Indedocs in Kentucky, or Pennsylvania, I think that the timing now, and I really hope that the media will help start changing the conversation to away from the demise of private practice to how it is an alternative that doctors and patients, would thrive in, and anyway, whatever I can do to help do that, happy to do that.
It's great. You've opened up my eyes. It's been very good to get to know you.
Well, thank you. Likewise.
Thank you for listening to The Business of Intuition. If you enjoyed the show, please subscribe, rate, and review on Apple Podcasts, Google, Spotify, or wherever you get your podcasts. If you'd like to learn more about Dean or Mission Facilitators Leadership, go to mfileadership.com. That's mfileadership.com.